questions in the audience following us through LinkedIn and YouTube, and we will then conclude with some closing remarks and a glimpse of some of the upcoming activities planned by the Asia Dengue Policy Working Group in the coming months. Next slide. So it is now my pleasure to introduce the speakers who will be leading today's presentations. Firstly, Dr. Jagath Amarasekera, Consultant Community Physician at the National Dengue Control Unit, Ministry of Health in Sri Lanka. Next is Dr. Ananda Wijewickrama, Consultant Physician and Dengue Expert, and also a Senior Lecturer in Medicine at the University of Moratuwa in Sri Lanka. And lastly, we have Dr. Lahiru Kodituwakku, convener of the Dengue Capacity Building Core Group at the Sri Lanka Medical Association. He was also a former Disaster Management Focal Point Medical Officer of Sri Lanka's National Dengue Control Unit. We are truly grateful and honored to have them with us today and share their knowledge and experience in dengue control management in Sri Lanka. Now, with our speakers now introduced, it's time to formally open today's proceedings. To set the stage for our webinar and share a few words of welcome, I'm pleased to hand over to Mr. William Brown, Director of the Asia Dengue Policy Working Group. Will, please.
Thank you very much, Kim, and a warm welcome to everybody joining us today. Really excited to bring this webinar to you, looking into the great work that has been going on in Sri Lanka on dengue control and management. Before we get to the most exciting parts, I just want to take a few moments to introduce ourselves, the Asia Dengue Policy Working Group, and our activities to date, as we are the group that wants to continue to push policy in the Asia Pacific region and bring you more insights, more sharing, and also to work with governments around the region on improved policy for better dengue control and management. So we were set up sort of the mid of last year, so about 1.5 years old now. And we are a working group under the ADVA, Asia Dengue Voice and Action organization. And we are really aiming to complete or work towards these 5 objectives that you see on the slide here. The ultimate goal is really to help accelerate the progress towards 0 dengue deaths by 2030. We also want to ensure that dengue is seen as a key priority at a regional level, but also across each of the countries within the region. And by elevating it as a priority, we hope to secure sufficient resources to tackle the problem. And a lot of that is going to come from generating evidence to support evidence-based policy change. As a part of our platform, we also aim to unify the sort of diverse sets of stakeholders and experts. So with events like this one, bringing together expertise from one country in the region, sharing that with others, and leveraging that collective expertise in the region. So that's what our platform sets out to achieve, is these kind of policy discussions and campaigns. On the next slide, also want to talk a little bit more about ADVA, which is our sort of parent organization, if you like. So ADVA is a scientific working group which has dedicated to improving advocacy and improving the situation for dengue across the region. They are the conveners of the Asia Dengue Summit, which is an event that has grown from strength to strength over the past few years. We have with us on the call today Dr. Francis Kwong, who's the overall secretariat for ADVA, who is working tirelessly as part of these efforts alongside us. So very pleased to be working under the ADVA umbrella. And a little bit also about myself, Kim, Rie, and Tammy, the team behind the Asia Dengue Policy Working Group. So we are from a non-profit called EquiHealth, of which the parent company is Vista Health, which is a global value-based healthcare agency offering strategic consulting and other professional services to the healthcare and life sciences sectors. So our roles are really to run the day-to-day operations of the Asia Dengue Policy Working Group, and to ensure that we can continue the mission of ADVA and the policy working group overall. You've heard from Kim. You'll be hearing from Rie later. And Tammy is with us working all the tech today. So thank you to them all. So just a very brief snapshot of our events to date. You can look at our website, or also if you follow the QR code you see on the screen, you'll see the outputs of our latest activity from a couple of months ago, which was a regional roundtable looking at scaling integrated dengue prevention programs. We have, as I said, started about a year and a half ago in April 2024. Since then, we have released a series of publications, posters, a policy map, and a white paper being the core deliverables, and also organized several key events around some of the major relevant conferences in the region. This is the next in our series, this focus on the great work that is being done in Sri Lanka. And we'll also have a couple of other events coming for you into the new year of 2026 as well, which you'll hear a little bit more about at the end after the webinar. So I think once again, thank you all very much for joining us. I'm really looking forward to hearing from our three experts today. I'll hand back to Kim to facilitate the presentations from here. Thank you very much.
Thank you, Will. So yeah, to commence our series of presentations, next slide, I would like to invite Dr. Jagath to provide an overview of Sri Lanka's National Dengue Control Program. Dr. Jagath, if you please.
Sorry, Dr. Jagath, you're on mute.
Yeah, okay, thank you very much. And also, first of all, I'd like to thank the organizers of this webinar, the Asia Dengue Policy Working Group, for the opportunity to reflect on the National Dengue Control Program of Sri Lanka and to share our experience with the global forum. We can move on to the, yes, so basically, when you look at the history of dengue, it was serologically confirmed in 1962, and we have had epidemics reported during that period. I think Dr. Lahiru would elaborate on those areas. Importantly, the notifiable disease, it was made a notifiable disease in 1996, so it's like maybe around 29-30 years back. And the National Dengue Control Unit was initially established as a coordinating unit in 2005, and then upgraded to a directorate in 2012. So this is about a little bit about the history. And the next slide, please. So this is a fairly interesting slide that shows the number of cases of dengue for the last 2000 to 2024. It's last 24 years, as well as the case fatality rate over time. So it gives a reflection of the burden of the disease as well as the certain achievements as well. So if you look at it from 2000 to 2008, it was like a lower reporting, lower sort of an endemic disease. General notifications less than 10,000, although 1 or 2 years had a little bit more. Then 2009, we had outbreak. So this outbreak, if you look at it, it may look smaller when you compare the next years that were to follow. But if you look at from 2008, where we had 6,000 cases, the very next year when you have 35,000 cases, it's like 6 times high. Then it was actually a big outbreak, which really stretched our resources in curative and preventive side. So that was like sort of a turning point. From there onwards, we have had higher reportings with 2 major outbreaks in 2017 and 2019. That is 186,000 and 105,000 cases respectively. So that has been the cases. And when you look at the case fatality rate in 2009, when we had that outbreak, it was like 1%. So roughly about 350 deaths for 35,000. But if we were to have the same case fatality rate at now, we would have a lot of deaths. But gradually, with the expansion of certain things which we can explain later, the case fatality rate currently is 0.05%. So it has been achieved. So this is about, in a nutshell, the last 20 years. Next slide, please. This is also showing some sort of the seasonal variation of dengue in Sri Lanka. We have 2 major monsoons or the rains. Southwest monsoon rain and the northeast monsoon rain. So those are the 2 monsoon rains. And corresponding to this monsoon rains, we have 2 peaks generally in the entire country. One peak is mostly from April, May, June, July, that period. And the next peak is mostly from October, November, December, and January. So those are the 2 peaks that correspond. But if you look at the last 2 years, 24 and 25, although we had the peaks, we were able to curtail the intensity and the duration of the peaks. But it's difficult to really prevent the outbreaks, but the outbreak levels through certain campaigns, which I will explain in the next slides. Next slide, please. Yes, this is the district variation. We have 25 districts. So basically, although 2024 reported high incidence in Jaffna district or regional director of health service, as we call it in the health sector, basically what we have is we have the districts Colombo, Gampaha, Kalutara, the Western province having so many high levels of dengue reporting in each year compared to the other areas. So this is the district variation. So this is the provincial contribution of the dengue cases. So basically, if you look at it, we have 9 provinces, but 1 province where the Colombo city is also located, that Western province contributes to about 43%. So nearly 50% cases are from this province alone. So basically, when you look at the high risk strategy, it's very important. If you can reduce the incidence in this province, you can reduce the dengue burden in the entire country by about 50%. So this is the contribution from different provinces. Next slide, please. Yes. So this is basically about the age distribution of dengue cases. So there's no major surprise here. The school-aged children and the working population is the ones who are mostly exposed to dengue. That is the picture we have had throughout. Next slide, please. And this is the gender, male and female. Male predominance is slightly more, around 50-55%, but then again, it doesn't show a major difference. The next slide, please. Okay, this is about the dengue viral surveillance. So one thing we have to notice that all 4 serotypes are present in Sri Lanka, but in the last couple of years, dengue virus 3 is the one that has been most prevalent. So that has really increased like 85%, 81% contribution in the 2024. But this year, although I have not put the statistics, up to now, there is somewhat increase in dengue virus 2 also. So still the majority of cases are dengue virus 3. So that is the picture, but the sample size is like last year only 100 samples. So that also we had to mention while going forward. Next slide, please. Okay, this is the entomological surveillance. We have entomology surveillance, which I will describe later on, but this is the proportion of the primary vector and the secondary vector in different districts. So as shown here, the Colombo, especially the Colombo municipal areas, the primary vector or the Aedes aegypti is the more prevalent vector compared to the albopictus. But when you go to the rural areas, you have the albopictus being more prominent. And the other side, the graph shows the premise index as well as the dengue cases. So premise index and the dengue cases for the entire country, whether we can have the premise index to reflect the entire country, that is a different debate actually. But if you look at the statistics, you will see that with the increase of premise index, with a lag period about 1 month, you get an increase of dengue cases. So that is basically the situation. So when you look at this, it's very obvious that when you have the premise index increasing, it is the time to act and prevent dengue cases. So that is how we have to look at this picture. Next slide, please. Okay, this is our national strategic plan for 2024 to 2030. So we have 2 very ambitious objectives. One is to reduce the case fatality rate due to dengue to 0 by year 2030. So that is in line with the WHO objectives as well. So and then the next one is to achieve the dengue case incidence below 100 per 100,000 population by year 2030. So both are very ambitious. And at the moment, 2024, if you look at it, we have the case fatality of 0.05%. And the incidence is about 228 per 100,000 population. So that has to really half. So by 2030. So that is our objectives based on the national strategic plan that is also available in our website. Next slide, please. Okay, this is about our dengue surveillance system for the disease surveillance. Basically, we have a web-based real-time disease surveillance system, which is called NDCU. So basically, it's a fully functional from the hospital to the field investigation. So what really happens is, once the dengue patient is admitted, they are informed, they are notified through the system to the medical office of health area. So medical officer of health is actually the structural and functional unit of public health or the preventive health, where in Sri Lanka it's divided into about 370 medical office of health regions. So in each region there is an officer in charge called the medical office of health. Then different MOH is divided into a different range public health inspector areas. So when this notification comes online web-based to the public health inspector, he goes to the field and investigate. So that is how it's functioning. Then we have another system called midnight total, where the midnight total basically is actually few cases, right? Few cases, all the hospital total midnight for that day is entered into the system. That gives the burden of the hospital. Let's say there are 50 dengue patients admitted on the or at the moment staying in the hospital, then that hospital will give a midnight total of 50. So that is important just to see the burden as well as to see whether the trend of admission of patients. So each patient, not like notification, the midnight total will basically reflect even 2-3 days if a patient stays, the aggregate number is reflected of the patient in the midnight total. So timely field investigation is a key activity that we hope to achieve through this system. And that's about our system. So the feedback, we have 2 feedbacks. We have a daily update, which is circulated to a wide health staff, and also a weekly dengue update, which is available in the web each week. So this is just a sample I have put where we have the district situation for the present week as well as the previous week and the previous year. Then we have the high risk MOH areas, and also the midnight total of key institutions or the institutions having high numbers and the deaths and their structure. So this kind of a structure is there for our feedback, which is available in the web each week. Next slide, please. So this is about the vector surveillance activities we conduct. We have the routine survey, the spot survey, and the focus investigations. So focus investigation is the place may change based on the need. For example, if there's outbreak, then we can do focus investigation there. Or if there is any flood situation or any situation where you need to do, then that changes. But the spot survey and the routine surveys are constantly in one place. More activities are conducted for the routine survey. For example, we do the immature surveys, larva and pupa monthly, then indoor and outdoor adult mosquito resting collections monthly, ovitrap surveys monthly, then human bait collection using double net quarterly, and insecticide susceptibility test annually, and on requirement we do bioefficacy test for larva and adult. So these are the ones that we do for the routine surveys and the techniques that are conducted. But those are the last ones are like we don't do very often. Okay, next slide, please. So this is about the intersectoral collaboration. So as you know, the dengue is beyond health when it comes to controlling and preventing disease. So it's the highest level presidential task force chaired by His Excellency the President is structurally embedded in the system. And then we have the ministers of different ministries, with health being the coordinator of this. And also then we have the inter ministerial collaboration and the provincial level, district level, divisional level, and village committee. So we have that sort of a structure going across to the grassroots level for intersectoral collaboration. So which is essential for dengue control. Next slide, please. Okay, this is something I just wanted to highlight about in what we do in our campaigns. I don't know whether it's done in other areas as well, other countries. So these special mosquito control campaigns, when we predict that we have a outbreak or when there's a little bit of increase of cases, then we conduct this kind of campaign where it's a vector control program. People go house to house as a team and then check for breeding sites and take action to correct them or advise on correction as well as the other actions that are required. It's a multi-sectoral approach, and these MOH office areas are selected based on high-risk strategy, cases, the entomology indices, and the increase outbreak potentials. So based on that only we select the cases. Not all the MOHs are selected, and we conduct this campaign, and media gives wide publicity. So the important thing is later on, basically, when you say this, announce that there is this campaign going on, people tend to clean their places because they anticipate they might be visited as well. So that is also indirect benefit in addition to the direct benefit of the awareness and cleaning or controlling the breeding sites in that areas. Next slide, please. Next slide, please. Yeah, so this is about the basically I haven't told any all the activities because it is just some things that maybe that we have to mention which may be different. So this is basically we check for ensure to keep the premises free of breeding sites, as well as we have a circular introduced by the Public Administration Ministry that says all the government institutes have to check for breeding sites once a week. So that sort of thing is there as a circular, and the others are like fish introduction, tempos introduction is as needed is done. And fogging, we do it when there is risk of outbreaks or increased transmission. So if it's an endemic area, there is 1 or 2 cases even in that area, you can do fogging because that reflects the infected mosquito population. And we have the thermal fogging, which is oil and water based, and coal fogging also conducted. Yeah, future expansion of the novel techniques. So we have done the Wolbachia project and the sterile insect technique. So the Wolbachia project, basically we have done it in collaboration with the World Mosquito Program Australia. In 2021, we did a pilot where 2 medical officer of health areas in Colombo district were taken and the release was done. So we are thinking of expansion in 2026, 2027. And another area that we have done is sterile insect technique. That was conducted in Gampaha district in one MOH area, medical officer of health area, in collaboration with the University of California and the International Atomic Energy Authority. And that also we are planning to expand in 2026 and 2027 period. I think, is it possible to go for two slides previously? I think I missed 1 slide, if it's possible. Previous, yes. So this is about the capacity building, which was very crucial for clinical management. I think Dr. Ananda would elaborate on that. So would elaborate. So basically, we have brought the case fatality rate to 0.05 from 1%, and clinical management guideline introduction, dengue death reviews introduction or initiation, and infrastructure of the hospitals like high dependence unit and portable ultrasound scan, hematocrit machine, developing infrastructure of hospital and training of clinical staff has gone a long way towards that. We can go to the yes. So basically, we have a good health infrastructure at grassroots level. So we have the MOH level that is with the range PHI level. So everywhere there is a grassroots public health infrastructure, and we have the support from the highest level and dedicated control program. So when I say control program, it's not the staff of our dengue control unit per se, but all the districts, the curative staff, then the supportive stakeholders, the other international organizations, everyone who is contributing towards this, we have a good dedicated system going. So that is also a strength. So challenges, the notifications are received mostly inpatient, and other thing is the individual engagement or the community sustainability is not adequate. So like waste disposal and everything, we see that during outbreaks, during the awareness only that is happening adequately. And waste management system is not optimal across the country. Some places have a good system, some places don't have a very good system. And another challenge would be to achieve zero mortality from the current low levels. Any program or any disease, when you have low level to zero is very difficult to achieve. So that is also a challenge, but it's a challenge. And intersectoral support, although it's there in basically in paper and also in the structure, only during outbreaks that we mostly see the effective, high effective intersectoral support in dengue prevention area. So these are the challenges that we have to overcome. So I suppose, I think in a nutshell, I have listed out certain programs of dengue control. So thank you very much for your patient listening. Thank you.
Thank you, Dr. Jagath, for the thorough and informative overview. Next, we will now continue with the presentation from Dr. Ananda, who will discuss the clinical management of dengue in Sri Lanka. Dr. Ananda, please.
Thank you very much, and I would like to thank the organization for inviting me for this talk and giving me this opportunity to share our experience on this. Are you sharing the slides, or should I share the slides?
You can share the slides, or we can share the slides. Either way works.
Okay, I will share the slide. Can you see the slides, please?
Yes, if you're able to put that into full screen mode.
Is it in full screen mode? You see?
If you click the yellow button on the bottom right,
Sorry.
the orange button. You can click on the orange button on the bottom right.
The play button at the bottom.
Yes. Yeah, in my screen it is in the full screen. Are you still not in the full screen mode?
No, we can see the other parts. Shall we share our screen?
Oh, all right. Okay. Please.
Okay. Just give us 1 minute, please. Okay.
Yeah. Next slide, please. Yeah. So I'm going to talk done by Dr. Jagath and about the changes to the guideline as well as to the management of the patients, and also the efforts we took to improve the clinical management and the impact of those management. Next slide, please. Yeah, so as you heard, it was first serological confirmed in 1962, and then we were having small outbreaks until 2009. And in 2009, we had a relatively large outbreak. Next slide, please, with 35,000 cases. And then the rate of high rates continued. And again, in 2017, we had a very large outbreak, the largest we ever had, with 186,000 cases. Now, mind you, all these are the numbers, or most of these are numbers who were admitted. Who are not admitted are, unless they were confirmed, are not reported. These were diagnosed. The probable diagnosis was made on dengue, may not have diagnosed serologically. Next slide, please. And the majority of these patients belong to above 15 years of age group. In fact, with this increase of numbers, we saw demographic transition. Previously, it was mostly a pediatric illness, and from 2000 onwards, this starts changing. And now more than 75% of patients belong to the age group of above 15 years of age. So as you can see, this in both these years, 2024 and 25, the right side one is 25. You can see the majority are of the belonging to that age group. Next slide, please. Yeah, this Dr. Jagath showed. I have added the 2025 figures also. So here we see a dengue 2 as well as dengue 3. It's predominant dengue 3, but we see an increase in dengue 2 as well. This was up to July this year. So now in 2017, it was mostly dengue 2, which was the outbreak. And then it was replaced with other serotypes, especially dengue 3. And so this is, we are a bit concerned about this increasing of dengue 2, because generally this has not only in Sri Lanka, in other countries also, dengue 2 has led to more complications and wider spread of the disease in many outbreak situations. Next one, please. These are the admissions to my hospital where I was working. That's the National Institute of Infectious Diseases, which is the referral center for adult dengue case management. We started this unit in 2011. And then in 2017, we had a large number of patients, that is 18,000, when we had this the largest outbreak. So basically, of the total number of admissions, we had 10% of admissions to my hospital, and this actually enabled us to have lot of experience, as well as we utilize this for training of other staff, which I'll be talking later. Next slide, please. As mentioned, 2009 outbreak had 1% mortality, and then it prompted an urgent review of existing management protocols. Next slide, please. And with these changes, as it was shown, the mortality rate, which was 1% in 2009, now has reached 0.05%. This is mainly with the improvement of the clinical management. You can see the case numbers, even though controlled, still were quite high. So therefore, there was significant improvement in the clinical management with the change of clinical management protocols. Next slide, please. So this included understanding of pathophysiology of dengue hemorrhagic fever, which is the hemorrhagic fever, which is the capillary leakage as the main driver of complications, and identification of this plasma leakage phase, which is named as the critical phase, although many of these patients, in spite of having plasma leaking, are not critically ill, but it is conventionally called the critical phase, where they have this plasma leakage, which is generally about 48 hours. And during this period, especially the need for the timely fluid replacement and the monitoring strategies. And in addition to plasma leakage, it was noted some patients, especially adults, can have significant bleeding, which is often occult. So unless these patients are monitored regularly, this bleeding will be missed, because this bleeding is not visible, mostly, especially at the early stages. Next slide, please. So in the key component, few key components of these guidelines are the probable diagnosis criteria, then uniform national monitoring charts, the frequency and the need of packed cell volume measurements, then the standard fluid management protocols, and the indication for blood transfusion. Next slide, please. Yeah, the first one is the case definition for suspected and probable dengue and regular follow-up of these patients as outpatient. So we have given criteria based on the WHO and CRO criteria to have the probable diagnosis, which is based on the symptoms, signs, and the changes in the complete blood count or full blood count. We are not emphasizing on doing NS1 antigen, even though whenever it is possible, it is being done. However, we have seen the specificity rate, less specificity rate, or rather less sensitivity rate. It is highly specific, rather less sensitivity rate in this, depending on the duration of the illness. Even when it was done within first 3 days, the sensitivity rate vary from 70% to 95% or so. So therefore, and also it is costly, relatively costly. So therefore, we encourage people to make the probable diagnosis based on the symptom, signs, and the full blood count changes. And especially during outbreaks, and it's now, since we are endemic, even during other periods, we encourage the healthcare workers and the doctors to do full blood counts on their patients on day 3 of fever. And also we encourage the laboratories to provide this report within 1 hour. And then depending on that, the medical practitioner will take the decision about the further management of these patients, as well as based on other symptoms and signs. if the patient is not admitted, generally on day 3, most of them will not be admitted, but they will be followed up either in the hospital outpatient department or in the general practice doing daily full blood count. So we encourage them to do daily full blood count, and then based on their symptoms, signs, and other parameters as well as the full blood count, we decide whether they need to be admitted and monitored carefully for complications. And in the meantime, we give specific instructions, written instructions to patients regarding what to do at home during this period, what to drink and what to not to do, and so on, not what drugs to take and so on. Next slide, please. Yeah, the second important step is to identify plasma leakage and bleeding. For this, we encourage the hospital staff to do regular hemodynamic and urine output monitoring. As in the outpatient department, they encourage patients to do this, and we do the hemodynamic measurements when they come to the hospital. And then when they come to the hospital, especially after admission, we do regular PCV monitoring, that is on-site PCV monitoring. And then from time to time, we do point of care ultrasound scan to detect plasma leakage. We have distributed portable ultrasound machines across the country, and it's relatively less expensive relatively than a bigger machine. And the medical officers are trained specifically for this purpose. They were given a limited training to detect plasma leakage by doing a point of care ultrasound scan for these dengue patients. Next slide, please. So as mentioned, the role of ultrasound has become very important. It's early detection of plasma leakage, and it helps us to guide the clinical decision making, and we promote it as a bedside assessment tool. This is specifically important that generally the plasma leakage was detected or was diagnosed with the rise of PCV, the 20% rise of PCV, as well as using the lateral decubitus chest X-rays to see the early pleural effusion. However, the importance of PCV, even though it is very important, it has changed, especially in the case of adult dengue patients where bleeding is common. This has been reported worldwide, the bleeding, the commoner nature of bleeding in adults, especially compared to children. So therefore, to detect the fluid plasma leakage, use of ultrasound has become very useful. Next slide, please. Then the third important step is the fluid management, to manipulate fluid within a quota, and then to use colloid when a lot of fluid had been needed and if the patient is still unstable, and then the blood transfusion when bleeding is suspected in an unstable patient. We have given clear criteria to decide when to give blood, when to suspect significant bleeding, and when to transfuse these patients. We don't give prophylactic transfusions, whatever the platelet count, even if it is 10,000. We don't transfuse the prophylactic platelet transfusion. Stop this practice for the last 13, 14 years, and we haven't had any problems. And of course, we discourage use of steroids for these patients. Next slide, please. This is this one, and the next slide, please. These are the two monitoring charts we use in monitoring these patients. The first one, that is if the patient is having not detected as having plasma leakage. This chart we use when we detect these patients when they are having plasma leakage. So this chart basically shows the amount of fluid given in the upper part. Each small square corresponds to 50 milliliters of fluid, and in the lower part of the chart, lower half of the chart, you get the capillary refill time, the pulse rate, the blood pressure, the pulse pressure, the urine output, and the hematocrit value. So the frequency of monitoring can be determined by the clinician who is looking after the patient. So this chart is generally prepared to monitor these patients hourly, but if necessary, they can expand, or if necessary, they can do the monitoring less frequently. And this chart is now an official document of the health ministry. So therefore, all the state hospitals are using this chart. The importance and the usefulness of this chart is this an intervention which does not cause any, basically very minimal cost, but this causes a uniformity of these patients, and also in reviewing of these patients, it has become very useful and important. And also in referrals, especially when we refer these patients, we get advice from referral centers regarding these patients by doctors who are working in the periphery. They send this chart through WhatsApp. So we know what has been happening over the last several hours to these patients, about the fluid, their hemodynamic status, and the hematocrit. So it gives a very good overview of the patient and the patient what has been happening. So this has become very useful in the management of these patients. And in fact, I would like to suggest the organization to consider having a prototype of this, so that the countries can adopt it to their needs. But still, the prototype can be used also not only in the management, even when you compare the management strategies, and also in research. So this can be very useful. Next slide, please. And this is the microhematocrit machine. There are various other types of machine. Again, a very low cost machine, and also the hematocrit is being done using the capillary tubes. Again, is very low cost thing. It gives quick results. Within 5 minutes, you get the results. If there's a problem, we can always do it. So it is reproducible. We have trained our nurses to do that. Needs very minimal training, and this has been a very useful tool which we use in ward. So we get the results of a patient of hematocrit within few minutes, which has been very useful in the management. Again, we have distributed these to all the wards, medical wards and the pediatric wards in the country. And this has contributed significantly to the change and improvement in the mortality rate. Next slide, please. So this is, I spoke to you regarding the ultrasound machine, ultrasound examination. So we use the portable ultrasound. The left lower one shows the gallbladder wall edema with the pericholecystic fluid, and the right side one shows the fluid in the hepatic surface and the hepatorenal pouch, where the fluid generally gets collected at the earliest areas of fluid collection, which is easy to detect. And with the limited training, no ordinary medical officer can use this and detect this fluid collection by the plasma leakage. Next slide, please. So as I mentioned, the death rates have come down significantly, and as Dr. Jagath mentioned, and next slide, please. Yeah, in addition to this, we review all the deaths. These are reviewed by an expert panel, and then we discuss it with the team who manage that patient. This is going as a learning exercise. So this is to see where we can improve management further. Even though we have reduced the death rate, the mortality rate significantly, still we see there's room for further reduction of this mortality rate. So therefore, we analyze each and every death, and this has been a very useful exercise to identify the gaps and also to correct gaps. And some of the key gaps we have identified are the not increasing fluid intake when the leaking is detected. So in patients who have significant leaking, they go into shock, and then not diagnosing bleeding, which has to be done used by clinical parameters and the PCV and the hematocrit. And then transfuse if the patients are unstable. And then, of course, still some patients buy NSAIDs over the counter, and some general practitioners tend to give NSAIDs without suspecting dengue. So this has become a problem because we see more complications in patients who have had NSAIDs. Next slide. Yeah, this is I just put this this on the next slide for the sake of interest. This shows this patient needed 5 units of blood to be stabilized, and there was no visible site of bleeding. Since he had the features of psoas spasm, we did the CT scan, which showed a bleeding into the psoas muscle. You can see the difference into psoas muscle. So that is where it had bled. And so it was obviously not visible outside. Next slide, please. This is another patient who had bleeding and had a little lump in the lower part of the tummy. Again, needed 5 units of blood to make her stabilize. And next slide, please. And this is a cross-section of the previous patient, cross-section of the abdomen of CT abdomen of the previous patient. You can see the differences in the rectus muscle. That is where the patient bled. And finally, the part of the muscle got necrosed, infected, and we had to surgically remove that, but she recovered. So this is the issue with these patients. They bleed internally, which cannot be, if it is to the gut, later, at least a day later, they will produce melena, but still that will be too late. But these patients, there will not be any focus to detect unless you look very carefully, which is sometimes difficult. Next slide, please. So therefore, our success story, I believe, depends. It's due to many things. We have changed our management protocol and trained the staff. Probable case definition, as I mentioned, and standard monitoring charts, regular PCV measurements, point of care ultrasound scan to detect plasma leakage. And we empowered nurses. We trained nurses and empowered nurses to monitor patients. And then therefore, we have frequent communication and early detection of problems in these patients, because they are empowered they are educated, trained, and empowered to look after these patients. And we provide regular training for nurses and doctors, especially at the referral center at the National Institute of Infectious Diseases. And then the doctors are trained to take decisions on using colloids and giving blood transfusions where necessary. So we do regular, as I mentioned, regular death reviews. And still, we believe there's further room for further reduction of morbidity and mortality, and need continuous training programs. Next slide, please. So we do national-wide training programs on guidelines, and we train the doctor. We have several mode of training programs. We have a short program of 3 days, and also extended training program for postgraduate doctors, trainees of a 10 days program. So we have sort of tailor-made training programs for the staff of them. And these are mainly conducted at the National Institute of Infectious Diseases with the help of clinicians from many other hospitals. Next slide, please. So the guidelines have improved the clinical decision making and early detection and proper fluid management, and we have training ensured consistency and improved outcome. In fact, we have extended this training to other regional countries also with the support of the WHO, and at the request of the WHO or regional office, we have conducted training programs for clinicians and nurses of Bangladesh, Bhutan, and Myanmar during the last year. And I believe this year also there will be next year also some programs are planned. I believe that's all. Next slide, please. Yeah. Yes. Thank you very much.
Thank you, Dr. Ananda, for sharing those valuable clinical perspectives. Next and lastly, we turn to Dr. Lahiru, who will present on dengue outbreak response from a disaster management standpoint. Dr. Lahiru, please.
Yes, thank you very much. Hope I'm audible.
Yep.
Okay.
Yep.
Okay. First and foremost, let me thank the organizers for giving us this opportunity to present the case of Sri Lanka's dengue management. Some of the best practices as well. So echoing on some of the areas that my colleagues already presented, I'll be highlighting the historical trends in dengue outbreaks, particularly on dengue outbreaks, and the platforms and also the efforts that we have done for dengue outbreak early warning and prevention. Then particularly on dengue outbreak response, the interventions that we are currently doing and also what we have done previously as well. Then a particular note on the civil-military coordination and multi-stakeholder response, because during outbreak times, civil-military coordination and also multi-stakeholder response is vital. And few notes on preventing a future disaster through dengue outbreaks, in case of dengue outbreaks, and the way forward. Next slide, please. Yeah. So as highlighted by the previous speakers also, the first case of dengue was serologically confirmed in 1962. During the period of 1969 to 1988, actually, there were multiple sort of dengue serotypes circulating in the country, according to the earlier archived reports from the early researchers. But particularly in urban areas. So this has to be noted, particularly in the early 60s and up to early 80s. The cases were confined to urban areas with multiple cases of dengue fever, but very few cases, clusters of dengue hemorrhagic fever as well. 1965 to 1968, the first reported outbreak was there for 51 cases of DHF with 15 deaths during the period of 1965 to 1968. Now, this particular period, the entire circulation was associated with dengue type 1 and type 2. From 1989 onwards, into early 90s, there were few outbreaks, but the most notable for each is, as echoed by previous speakers, the case fatality rate was very high. And in 1996, an epidemic was reported with more than 1,200 DHF cases with 54 deaths at a CFR of 4.2. So as you can see, the CFR at that time was very high. Next slide, please. So in late 90s and also in 2000s, the disease trends sort of started to change with more extensive geographical distribution across the country, because as I said earlier, the outbreaks are confined to more urban areas, but in early 2000, we saw the disease is sort of transmission of the disease towards the semi-urban space and also the rural settings with more frequent outbreaks. And also with that transition, we saw the magnitude and the frequency of outbreaks are also increasing. In 2009, also there was large outbreak with 35,008 cases with 346 deaths with a CFR of 1%. So because of this increasing magnitude and the frequency of dengue outbreaks, the epidemiology unit with the coordination unit at the National Dengue Control Unit, which was earlier called, the name of the National Dengue Control Unit, they declared dengue as a notifiable disease in 1996. But the most significant event in case of dengue outbreaks in Sri Lanka was in 2017, where the country recorded the largest dengue epidemic in the country with over 186,000 suspected dengue cases and 440 fatalities, which included deaths among children and also among pregnant mothers. Next slide. Now, this is a reflection of the incidence of dengue over the years from early 2000s to 2024, as previously highlighted by my colleagues. Like you can see, the incidence is increasing, but the case fatality rates are decreasing, partly because of the trainings and also the capacity building efforts of clinicians that we had over the years, which helped us to sort of reduce the case fatality rate. But when it comes to dengue outbreaks and also the incidence of dengue, it keeps on sort of rising, partly because that is why we call now dengue is endemic to the country. Next slide, please. So now this 2017 dengue outbreak has been researched many times, and also, as I said, it was a notable sort of a event in our entire dengue sort of spectrum. Sorry, the previous slide. Yeah. So there are few characteristics of this 2017 outbreak. If you carefully study these 2017 outbreaks, there are good lessons to be learned for not only for us and also for our South Asian and Southeast Asian colleagues. Now, 1/4 of the total dengue cases in 2017 was reported during the week of 27 and 31st week. Now, this corresponds with our normal routine patterns of dengue transmission, as highlighted previously. Also, we have two monsoonal seasons, southwestern and northeastern monsoon. Now, for western monsoon, which sort of correspond with these weeks of like 25th to 32nd week of the year, the most of the cases are sort of confined to the western province and also the say like the wet zone of the country. But in the northeastern monsoon, which happens in from early December now itself, now northeastern monsoon has been established over the country now, which goes till the March, February of next year. The cases are mostly reported from the northeastern provinces. Now, this particular outbreak, even though it was reported across the country, majority were cases from the western province itself and coincides with the monsoonal patterns. Now, if you take the weekly average reported dengue cases in that particular year, 2017, it was significantly higher than the average of preceding 5 years. For example, it was 3,517 cases in preceding 5 years, but the 792 cases in preceding 5 years, but this particular year, it was 3,570 cases. Now, as I said earlier, most of the cases were reported from Colombo and Gampaha districts, which is located within the Western Province, the most densely populated districts in the country. And also on a national basis, 10 districts reported above average dengue cases in that particular year. Sex distribution wise, similar sex distribution, and if you consider the age cohort, the highest cases were reported from the 20 to 29 years of age cohort. Now, this is very important. I think Dr. Ananda also highlighted this point. Now, primarily, this was caused by dengue virus type 2, right? And also, when we did the genotyping, it was a cosmopolitan genotype reported in Sri Lanka. So the notable point was it was a shift from the previously predominant dengue virus type 1. Now, why this is significant is when there's a sudden change of dengue viral serotype, the impact of the outbreak is much more higher because we have a sort of unimmunized sort of a population cohort for this particular viral type. So primarily it was caused by dengue 2. Now, there was this debate also among the researchers about the impact of the weather patterns, particularly on 2017, because in 2016, Sri Lanka experienced a major flood. Now currently we are experiencing floods. Now, the previous major flood was in 2016. Now, there was always a debate among the researchers about the influence of weather for this particular 2017 event. But when you consider the mean annual rainfall for Colombo district in 2017, actually 2017, the mean annual rainfall for Colombo district was lower than the 2020 to 2016 period, right? 9,019 versus 2,400, right? So it was low. So the influence of weather, even though we had a sort of a major weather event previous year, this particular year, the impact of weather was not that significant. And also, if you sort of scan through some of the vector indices, for example, Brito index for 2017 was similar to the Brito indexes of 2013 to 2016, right? There was no major difference according to the researchers. So the significant factor, if you take out the Brito index, they do have impact. But if you take out the Brito indexes, the vector control indices, and also the weather patterns, right? The significant factor which has changed was the serotype of the virus. Yeah. Next slide, please. So to avoid such kind of a sort of a 2017 outbreak, because we were stretched to our limits, health capacity wise, and also public health perspective, we were stretched to our limits during the 2017 outbreak. So there are few early morning platforms that are operational right now. One was described by Dr. Jagath also. The epidemiological surveillance unit was surveillance platform is NADSIS. So suspected dengue cases are reported from all MOH areas to this particular web portal. Now, Medical Office of Health areas are the grassroots level public health unit in Sri Lanka, where they collect all data, particularly on dengue as well. So all these data will be sort of inputted into this system. And also we have hospitals, where hospitals will also input all suspected dengue cases or all suspected fever cases into this particular NADSIS surveillance system. Entomological wise, we have routine surveillances, sentinel site surveillance, and spot checks. And these sentinel sites are also calibrated according to the previous experiences of outbreaks and also the risk status, which I will explain later. This is the third one is very important. The hospital capacity or surge capacity monitoring system. We have what you call dengue midnight surveillance across, if I'm not mistaken, around more than 70 sentinel site hospitals covering all high-risk areas in the country, where they give us on midnight the number of suspected fever patients or dengue patients in their wards. So this is actually sort of a point prevalence where we can get an idea about the cases that are draining into these specific hospitals. And also, we can get an idea whether the capacity of these hospitals are exceeding at any point, because we know their capacities, the bed strengths, and also the healthcare workforce available. So we can get a better idea whether these hospitals are managing their situation very well. So this is a very important surveillance mechanism for National Dengue Control Unit. Sometimes this is the basis for resource allocation for hospitals as well. Climatological surveillance, I must admit that when you compare some of the Southeast Asian partners, our climatological surveillance is not that much developed, but we do have a sort of a surveillance mechanism through DMOS platform, which take care of the variables, including the climatological variables, the water availability, and also the epidemiological variables. But it is not that extensively used within the country, but we do use them for some predicting purposes. And also we receive monthly forecast, weekly forecast, actually 3 monthly forecast of weather from the meteorology department. But the challenge is to overlap these all weather data with the current epidemiological data set that we have within the National Dengue Control Unit. Next slide, please. So for dengue outbreak prevention purposes, not for response purposes, prevention purposes, we actually categorize dengue into three, the entire country in the MOH areas. We have around 366 MOH areas across the country. So for the purpose of outbreak prevention and response, we categorize these MOH areas into three main categories. One is priority high risk, the second one is high risk, and the third one is low risk. Now, earlier, what we sort of, as a criteria, what we used was the population density of these particular areas, number of pediatric cases reported, because that will give us an idea about the sort of area circulation, whether it's inborn sort of outbreak. And high-risk premises, particularly, I will explain you in later slides what are the high-risk premises for dengue in Sri Lanka, and also some of the vector indices like Brito index and premises index. But now we also we have expert sort of resource persons within the National Dengue Control Unit on different aspects on vector control and also epidemiological surveillance and outbreak response. So they do also sort of validate this data coming out of according to these criteria. Then only they will decide whether these are the sort of priority high-risk areas, high-risk areas, or low-risk areas. Accordingly, they will manage their interventions on the ground. We do have routine source reduction campaigns and also vector control programs planned according to that risk status. Right, planned according to that risk. Actually, in the weekly report, weekly dengue summary, which is issued from the National Dengue Control Unit, they identify the high-risk areas for that particular week. So accordingly, they will do the interventions. We do have localized sort of mosquito control programs during the pre-monsoonal season, because before the start of the season, it is very important that we clean our premises and we sort of reduce the vector breeding in those sites. So we do have localized special mosquito control campaigns. And we have two sort of, as I said, we have two monsoonal seasons. So we have two national level special mosquito control campaigns, where the entire teams, public health teams, will be mobilized with the help of the armed forces, with the help of police, and with help of other stakeholders like the civil society organizations, uh, to sort of for source reduction, for public awareness, and so forth. Yeah, next slide, please. So this is one of the, it's in singular, sorry, but I'll explain you. This is a summary sheet of the special mosquito control uh, program, one of the special mosquito control programs. If you see the number of premises that they have examined, it's like 128,824 premises were visited by these public health teams. And also they have found there are potential premises for dengue breeding around 31,445 sort of premises. And if you see the overall the number of premises which were found with actual dengue larvae, it's around 4.7% of the total cases. So they go into this extent to examine premises before the monsoon, so that the premises are clear of dengue breeding places and we can avoid a sort of an impending outbreak. Next slide, please. Yeah, before I come to this slide, I would like to also mention, like in a Sri Lankan situation, in a dengue sort of outbreak, these high-risk premises, right? So although the houses, the individual houses are sort of identified earlier as high-risk premises, we see a trend now that some of the construction sites, particularly in the urban areas like the Western Province, are fastly becoming a major sort of a high-risk premise category, and also the government and public places. And the third category is schools. Now, this is very important in a very Sri Lankan context, because as Dr. Jagath highlighted, around close to 25% of the total dengue cases are school-going age children. So schools are being identified as one of the major high-risk premises when it comes to dengue prevention. Now, for special circumstances, for example, now suppose you have a national level examination or national level program. So different requests come from these ministries for the Ministry of Health to make these premises where the examinations are held to be dengue free. So we do at the National Dengue Control Unit, we do conduct special mosquito control programs for identified these special events. And also we issue operational guidelines for disasters for dengue prevention, because as you all know, after a major flood or a landslide, there is always high risk of a dengue outbreak in those areas because of the water stagnation and so forth. So operational guidelines are issued to the regional health authorities on how to prevent impending dengue outbreak, and also what are the vector control activities, what are the personal protective measures that we can advise people, and what are the sort of the treatment modalities available. All those things are sort of included in these specific operational guidelines, which are issued during or after disasters. And also, if we, from our surveillance platform, if we see that, like from the climatological surveillance, if we see that the rains are increasing, we always issue these operational guidelines again and again, so that the people are sort of informed of the impending danger. Next slide, please. So when it comes to dengue outbreak response, there are several notable factors from a Sri Lankan experience. The most notable one is the government mandate at its highest level. We have a presidential task force for prevention of dengue, which is chaired by His Excellency the President himself, or his presidential secretary, where all ministries concerned. For example, if like the Ministry of Education, the Triforces, police, the Ministry of Urban Development, roads, anyone who is concerned, anyone who is relevant to dengue prevention is sort of convened through this presidential task force. And we have a clear set of guidelines for each and every ministry to follow. and they are being asked about their actions at this particular presidential task force, and this is replicated in the provinces in a major sort of outbreak as well. On a practical grounds, coordination with different ministries is challenging, but since we have this particular presidential task force during our outbreak situation, the coordination has been sort of very easy because of the centralized structure that we have within the country. We do have also establishment of district and village level dengue committees, but operationality and functionality vary within different districts and within the sort of the lower levels of administration. We also, in a dengue outbreak situation, we also sort of liaise with the Disaster Preparedness and Response Division at the Ministry of Health, which is the coordinating agency for disaster response and preparedness in the Ministry of Health. We do have a sort of a public health emergency cell within this particular unit. So during a major outbreak or during nationwide programs, for example, as I said, national level dengue mosquito control programs. This is where the management and also the planning processes happen, and also a thorough monitoring and evaluation on a daily basis, right? All these data from the national programs will feed into the systems of National Dengue Control Unit and as well as the Disaster Preparedness Unit, and it will be evaluated on a daily basis during a program where regional epidemiologists sort of explain their sort of processes and what are the challenges that they have faced during the dengue outbreak response. Special source reduction campaigns and also adulticiding and larviciding, those are routine in outbreak. And strengthening hospital capacities. This is very important. During the 2017 outbreak, actually, as I said, our sort of capacity was exceeded. So we have to ask for the help of the Triforces to sort of facilitate some of these processes, right, within the hospitals itself. For example, the laboratory services as well, right? So this capacitating these hospitals, especially in most of the teaching hospitals and also the large hospitals, we have a unit called dengue high dependency unit. So this is particularly sort of addressing the high risk dengue patients that are coming into the hospitals. So we have all the required facilities in this particular unit to cater for high risk patients. As Dr. Ananda mentioned, all the equipment like the ultrasound scans, the patient monitors are all sort of in this particular unit so that they can manage and closely monitored, right? In the Ministry of Health, we do have a separate wing called the Health Promotion Bureau, which also sort of help us in the public awareness during a dengue outbreak. But within the National Dengue Control Unit itself has the capacity to sort of do public awareness. Now, the main portal of these public awareness campaigns are through these national campaigns. We do public awareness. And in these national campaigns and also some of the localized source reduction and dengue prevention campaigns and also outbreak response campaign, there can be legal action as well for repeated offenders. So legal action is used not as a tool of punishment, but for the repeated offenders, particularly say like if a large construction site is ignoring health advices repeatedly, so legal action can be taken for these particular premises, and there can be a fine, and also they will be asked to sort of clean their premises and produce a report to the closest medical office of health area. Then the medical office of health officers will go there and inspect the site, whether they have cleaned it or not. And that process is also available for dengue outbreak response legal action processes. Next slide, please. At the hospital level, particularly in major hospitals like the National Institute of Infectious Diseases, where Dr. Ananda was working previously, we have what you call fever corners, right? Particularly in outbreak situations, we have these fever corners because we need triaging of patients because of the sheer number of patients that are being admitted into the hospitals. Now, at the NIID or National Institute of Infectious Diseases, we call this 4C corner or Continuous Care Coordination Center. So we triage patients, we admit patients who are in need of admission, clinically assess them, and the other patients we give ambulatory care or we ask them to go home. We sort of educate them how to monitor, and we ask them to come back on certain intervals with some of the reports and assess them. So this particular mechanism is available just to sort of manage our surge capacities within hospitals as well. Because in a large outbreak like 2017, there is always the potential, because of the sheer numbers of the patients, there is always the potential for exceeding of capacity of these hospitals. As I said earlier, we have established from the National Dengue Control Unit and the Ministry of Health itself, Dengue High Dependency Unit. There is always liaising with public health teams happening within the hospital premises also, because dengue breeding can happen within hospital premises during outbreak. So there are routine programs to see whether the hospitals are free of dengue breeding. And also during large outbreaks, centrally we also distribute some of the repellents through civil sector coordination and also donations in case of a large outbreak. And the routine patient awareness is also ongoing during outbreak. Next slide, please. Now, as I said, through the Presidential Task Force, we have been able to harness the sort of the support of the Tri-Forces and also Sri Lanka Police, particularly the Environmental Protection Unit of the Sri Lanka Police. So during our national programs, national mosquito control programs, there are 4-man teams. Suppose now we have a public health officer, right? We have an armed forces officer. We have what you call a dengue mosquito control assistant, a special card that goes from house to house to see whether the premises are clean and whether there are sort of dengue breeding inside. And we also have entomological officers accompanying. So this team of people will visit premises, high-risk premises, and see whether these premises are dengue-free. So for that, the civil-military coordination is very important. That is why at every national program, there's a separate cell from the armed forces and also the police to handle manpower. They provide us with manpower in outbreak situations, and through Disaster Preparedness and Response Division and National Dengue Control Unit, we coordinate the entire sort of process. So they sit on this special operation bodies within the National Dengue Control Unit and also Disaster Preparedness Unit during these national control programs and during a national level outbreak, so that we can coordinate manpower and also their expertise for the dengue control programs. Yeah. Next slide. So on a final note, what are the things that we like seeing all the challenges during a dengue outbreak, and what are the things that we must improve and also we must focus on? Like, I think the first one should be, given the sort of intrinsic sort of relationship with the nature, right? With the changes happening with the climate change, also it's always good for a country to have pre-monsoon preparedness. So we have to strengthen our monsoon preparedness. And also targeted intervention during monsoons, right? So here and there can be exceptional level of monsoons, like the current disaster that we are experiencing. So we have to be very vigilant in the next 3 to 4 weeks for a possible dengue outbreak. So the interventions are right now going on, with the operational guidelines are given to the regional people. As Dr. Jagath highlighted, we do have a dengue zero surveillance in high-risk areas, but the sample sizes are very limited. So we need to have a sort of a nationally representative sample to give a very correct inference about this serotype that are sort of circulating in the country. What we have is good enough for operational purposes, but for a sort of a large understanding of the entire dengue zero prevalence status in the country, we do need to sort of expand on this area. Strengthening epidemiology surveillance, vector surveillance, and also amalgamating these epidemiological surveillances and the vector surveillance into climatological surveillance. That is very important with the changing climate patterns, and also we observe a change in the monsoonal patterns as well. Strengthening hospital capacities and also multi-stakeholder involvement is very important. And also a thing that we have to note is the multi-hazard scenarios perspective of the current disaster spectrum. Like, we have dengue and COVID-19, we have dengue and floods, we have dengue and droughts. So these things come in a bundle. So in case how we respond, because our hospital capacities will come to a stretch at this moment because they are handling multiple disasters. So on top of that, if we have a dengue outbreak, how we manage. So the operational guidelines and also the awareness programs has to be sort of tailor-made to accommodate this particular requirement. And finally, we are now in the process of identifying triggers for anticipatory action. Now, anticipatory action protocols are the latest version of the disaster risk reduction platforms that we have. And Sri Lanka has also adopted anticipatory action protocols, and there's a separate technical group working on that. So they have identified dengue as a major area for anticipatory action. That is a first in South Asia, because in all other South Asian countries, they have only identified floods or landslides like natural disasters. But in Sri Lanka, we have identified a biological disaster, dengue, as one of the areas that we need to be focusing on. So we are currently in the process with some of the civil sector society people like the Sri Lanka Red Cross and also the technical group that I have mentioned to to study the triggers and develop triggers for specific anticipatory action protocols. So, in a nutshell, this is the dengue outbreak prevention and also response capacities within Sri Lanka system, and these are the best practices and challenges that we have faced during over the course of last 2 to 3 decades. Next slide, please. So if you want to get more information, I think it's important that you visit the National Dengue Control Unit site and also Epidemiology Unit site and National Institute of Infectious Diseases, because this is the place where, as Dr. Ananda highlighted, some of the international teams are coming for trainings. Since now we have received requests from some of the Mediterranean countries and also some countries in the Europe, because since they are also seeing a trend towards that, beyond global south, they are also seeing a trend of dengue towards that particular continent. So we have also received some requests for training. So this particular hands-on skilled training, which covers the curative and also the public health perspective of dengue management, is happening at the National Institute of Infectious Diseases. So we would like to invite any partner who is willing to explore this option. Also, there are spaces for exploration and looking at the synergies that we can also consider. Next slide, please. So this is a team. Actually, I put this picture into the final slide to show you how the multi-stakeholder involvement is happening in the ground at Sri Lanka's dengue outbreak prevention and response program. So you can see public health inspectors who go from door to door to see the premises and inspect premises, and armed forces personnel, and also the mosquito prevention assistants going with the team. So this is the team that educate people and also see whether the premises are clean, and whether we can see any dengue bleeding inside these premises. So thank you very much. I would like to acknowledge the director and the staff, especially the technical staff of National Dengue Control Unit, Ministry of Health, President and the team of Sri Lanka Medical Association, Disaster Preparedness and Response Division within the Ministry of Health, and also National Institute of Infectious Diseases. Thank you very much.
Thank you very much, Dr. Lahiru. It was a very informative presentation, and we would like to go into the next section, which is questions. And I think just to share my thoughts as I listened to all three of the presentations, I think it's very impressive how comprehensive the dengue prevention and outbreak response efforts are in Sri Lanka. And we saw throughout the presentation as well the spike in cases in 2009 and afterwards that decline. So I think my first question that I have for the team, and I'll share the next screen where others can also pose questions, and we'd like to open the floor for those who are listening in to share questions through Slido. So let me just share that on the screen as well as I ask my first question to the panelists. So my question is, how did the Sri Lankan government have the first, how do they prioritize dengue to be such a infectious disease that need to be prioritized to put a presidential task force together. It seems that the ministries from health, education, environment are all cooperating very well, and I think that's very not as common to see in other countries. So I think I would like to understand how the Sri Lankan government was able to put this together and how the cooperation has worked so successfully. I can maybe Dr. Lahiru, if you'd like to start, since you had shared that point first.
Yes, I think Dr. Jagath may be able to sort of give some inputs. Like now in public health emergency space, dengue is the sort of the most important public health emergency that the government has to handle in Sri Lanka. So obviously the priority is like for dengue, but before 2017, actually, it was sort of a class. It was sort of isolated approaches from different ministries. So once we had the 2017 major outbreak, so government saw the need for a sort of a comprehensive platform where we can have a sort of a cohesive action. This is where the mandate for particularly this presidential task force was taken, and it was strengthened because there were few platforms where government has been involved in dengue prevention and control previously as well. But during 2017, this was strengthened so that next sort of a outbreak can be prevented. So Ministry of Health will always be the technical body that advising on the government on the particular prevention methods and interventions that can be taken. The Triforces will be the logistical and also the human resource support, and also other ministries on their specific technicalities. For example, education are mandated. And we do have a guideline for this particular operation, and every ministry has a task, responsibility, and a responsible person. As I said earlier, sometimes on operational level, there can be challenges, and we experience challenges continuously also. But for platform wise, given the mandate of the government, this is working very well. Dr. Jagath can add a few more points, I think.
Yeah, I think Dr. Lahiru mentioned everything. Sorry, my camera is not functioning, but I can explain. Basically, I think what you said is correct. How it has evolved, and another area that we can look at is that we have the provincial and district level coordination meetings. These are the general coordination meetings for any administrative purposes that are held monthly. So dengue is one of the agenda items. So that also helps basically keep that dengue situation and the dengue control within the administrative structure of the purview of the other sectors as well. So in that meeting, if the regional director of health service or the provincial director of health service or the medical officer of health of that area says this increasing and these are the issues. Let's say a person says it's the education the schools are having, or if another person says the issue is with the construction or the garbage disposal, then and there the decision is taken at that sort of coordination meeting. So that's just to add up to what Lahiru mentioned.
Okay, thank you very much. And I think we have one question from one of the participants. So the question is, if any subnational areas, have there been a record of seroprevalence above 60% of 9 years of age? And if so, is the dengue vaccine being considered there? If anyone would like to answer that question first.
I think Dr. Ananda would be better placed.
Yeah, I think I don't have the seroprevalence data in my hand at the moment, but in few areas, a few small pockets, the seroprevalence was about 60%. However, as you know, our country is a fairly small country.
No, I think there's some technical issues on Dr. Ananda's side. Just give him a minute until he's able to join. I think maybe as we wait, we can pose another question. I think this question is for Dr. Jagath, who
He's back, I think. He's
okay.
back.
Sorry, I had a sudden power breakdown. Can you hear me?
So if you can off your video, I think it will be much clear.
We will give him another minute to
Yes.
join again. My question is for Dr. Jagath, who is talking about the different reporting systems, and that there's this weekly dengue update by the National Dengue Control Unit. My question is, there's a lot of information on reporting that comes out. How is the information being used, and how is it encouraged to being used? I think sometimes we report information, but it is not always used effectively or not all. So how, from your understanding, are some of the best practices to make sure that these reports are being used in an effective manner for resource management and for outbreak management?
Yeah, so I think that's a very valid question. So one aspect is that, as I think Dr. Lahiru also mentioned earlier, our midnight totals and the feedbacks, those things are used for resource allocation, for organizing training, because where you have high number of dengue patients admitted, so they are given sort of a priority in that sense. And also in some other aspects also, like if you consider the investigation, timeliness of investigation, every month we analyze the date of admission of the patient or the date of notification and the date the investigation was done. So we analyze by district, provinces, and then MOH areas also, and then we give a feedback in that sense also. It's not a feedback that is posted on the web, but we give a feedback, and also that gives the regional directors of health service and the regional epidemiologists and the provincial directors to improve their timeliness of investigation also. So that kind of strategy has worked. So the timeliness of investigation also has improved over time. So that is one other way. And also this information is taken by the media also. The weekly update is taken by the media, and they present it in the electronic and the papers, and they say, okay, up to now this much of dengue cases reported, this much of in this district. So they elaborate on those reports and give a feedback to the community also through the media using this. So when we have this kind of comprehensive feedback system, which is utilized by this different organizations and media also, then the figures are uniform. So if there's outbreak, then the media reports it as outbreak. So like that, the figures are uniform. So that's how it's kind of utilized.
Great, thank you very much, Dr. Jagath. And we have another question from one of the attendees. The question is, how are AI tools used in dengue outbreak prevention, tracking, and response systems?
Yes. Now, as I said, like for the DMOS sort of early warning system, there is a part of AI also sort of being used as of my knowledge, but I'm not a technical expertise on AI, so I can't elaborate. But I must say, like the transition from the regular sort of platforms to AI has been a little bit slow. when it compares to sort of some of with the advances that now are happening in AI. But we do sort of consider this as even in our national strategic plan, dengue early warning and also forecasting has been identified as a major sort of area of concern for us. So in future, I think Dr. Jagath might also add these innovative platforms with the experts available and also some of the universities in Sri Lanka, because for different perspectives, we have been liaising with for research and also other technical inputs. We have been liaising with the universities. And also most recently, not per se AI, but most recently there was a working collaboration with the National Institute of Infectious Diseases and University of Moratuwa, which is the major technological university in Sri Lanka. But I must admit, yeah, the transition has been a little bit slow on AI front, but we do consider it as an important area in forecasting and tracking, as you said. Yeah.
Okay. And if it was to be incorporated, would there be a lead team or department that would be using that?
So in the Ministry of Health, we do have a sort of an information unit and also experts in AI. Say like we have a specialist group called the Biomedical Informatics Consultants within the Ministry of Health. So the services of these people will be definitely sort of incorporated in such instances with the support of the particular technical unit within the Ministry of Health. And also there are enough like for example within the CSO space and also within the sort of tech space, there are sort of players that are sort of actively sort of developing instruments on disease forecasting, not per se per dengue but for others as well. So these assistance can be sort of incorporated, and we are very open for that. Yeah.
Thank you very much. And now that we have Dr. Ananda back, perhaps you could help answer the first question on vaccinations for 9-year-olds of age.
Yeah, I'm sorry, we had a power breakdown. Yeah, So as I said, we have pockets of areas where seroprevalence is high. However, when you take majority part of the country, the seroprevalence is less than 60%. And also, as you know, we are a small country, and there are a lot of mixing of people from area to area. So therefore, and in addition, at present, the prevalent serotype is type 3, for which the vaccine is not effective. So therefore, we have not decided to deploy the vaccination at present.
I see. All right, understood. Thank you. And perhaps we can then go to our last question for today. The question is, did the dengue program impose any mechanisms to monitor healthcare professionals' capabilities beyond clinical guidelines and training? Perhaps Dr. Ananda, if you'd like to start that answer first.
Yeah, I'm not very sure whether I understood the question correctly. Now, one example we have been mentioning is the death reviews we do. And also we do analyze the near miss cases also, where we try to analyze the capabilities mainly on detection, monitoring, and also detection of complications, monitoring, and also decision making. Capabilities of nurses and doctors, especially the specialists too, by discussing those things, and because we see there's a room for further improvement of the care.
I see. And yeah, Dr. Lahiru, did you want to add to that?
No, I think Dr. Ananda explained it well. Apart from that, if I'm also not very clear about the question, but let me frame it this way: like for monitoring of healthcare professionals, for example, now we have specific instructions for healthcare professionals from the professional colleges and also from the Ministry of Health on use of some of these drugs. For example, NSA use in dengue management and so forth. So that there is not per se a audit process, but we we have our eyes on these specific areas, so that in case we see repeated sort of offenders, so-called offenders, or who are sort of diverting from the instructions and also the national guidelines that are being given, we do sort of have an awareness program for them on these specific aspects of what to use and what not to use, and how you can sort of manage your clinical expertise with the current guidelines and also instructions within the ministry. That program is there, and we have implemented that. But it's not a fault-finding mission per se, but to upgrade their knowledge and skills on the best practices in dengue management. Yes.
I see. Okay, thank you very much. It's very comprehensive. And I think just given time, we're going to close the questions, but I would like to thank all of the speakers again today for sharing Sri Lanka's best practices in dengue management and control. And with that, I'd like to hand it off to Kim, who will share some of their closing remarks.
All right. Thank you, Rie. Yeah. On behalf of the Asia Dengue Policy Working Group, I would like to once again thank our speakers today and also the audience joining us online for participation and engagement in this webinar session. Your dedication to improving dengue management and prevention is truly appreciated by us and everyone here in the team. All right, so before we close, I'm pleased to highlight a few upcoming activities of the Asia Dengue Policy Working Group. Firstly, we will soon be co-hosting a webinar with the Singapore Red Cross, focusing on community-level dengue prevention and innovative approaches such as AI-supported mosquito mapping. This is slated to happen around February of next year. And in January as well, we are also pleased to announce that the Asia Dengue Policy Working Group's membership directory is also set to launch next year. So this directory will serve as a platform designed to connect stakeholders, foster collaboration, and improve and promote sharing best practices across the region. So yeah, specific details of the next webinar and also the launch of the directory will be released at a much later date. So do keep an eye for those updates on our social media pages such as LinkedIn and our website. Okay. So with that, I would like to thank everyone once again. We encourage you to visit our website and follow us on LinkedIn to stay informed about our latest updates, resources, and upcoming activities of the Asia Dengue Policy Working Group. So yeah, looking forward to having you again at our future events. And thank you.
Thank you.
Thank you. Thank you very much.
Thank you very much.
Thank you very much.